and Health Communication Department, and I will be moderating this panel. We have 5 panelists, and this being a practice-based presentation panel, literally we are looking at practice-based experience, what people have been involved in. It's not theoretical in nature, it is practice-based. So there are good insights on how people have been involved into a number of activities, looking at integration-related work. How have we been able to integrate COVID-19 activities or vaccination programs into our routine immunization or vaccination programs in our countries? How have we been able to look at community social networks and leverage on these social networks to be able to create demand? And how best have we been able to look at community structures, respecting these structures for proper community engagement interventions as one of the means to increase demand for vaccination programs? And then the other insightful component is how do we leverage on our environments, looking at culture-specific issues in our countries, in our regions, to be able to address components of demand. We are picking up from the earlier sessions that have touched base on a number of issues, and we have a team of senior colleagues who are going to be joining me up here to share the experiences with us. One of them is Carla Toko. Carla, kindly come and join us. Carla is a senior manager in charge of advocacy and communications at the VillageReach in DRC. You're welcome, Carla. The second panelist is Yatender Singh, who is a program manager, Project Concern International. From India. You're welcome, Singh. The third panelist is Muhammad Zia Muneer, who is a manager at IRD Pakistan. My fourth panelist is Thomas Mavuto. Thomas is the Chief Health Promotion Officer with the Ministry of Health in Malawi. And my last panelist is Dr. Sangwe Clovis. Dr. Sangwe is the founder and body president of the Rural Doctors and associate at Clinton Health Services Initiative, Cameroon. So as I said earlier on, this is a technical practice-based presentation panel. We are looking at the different panelists and what they've been able to achieve in relation to increasing or driving demand for vaccines or vaccination programs in their countries of operations. And we hope that we should be able to pick through or boil a leaf from the practice-based experiences to enable us to be able to restructure our programs in our countries and our regions, and to be able to provide technical support to our countries or areas. And as you have already been told, that the component of creating demand or the pillar for demand creation is always forgotten. It's talked about, but it's always forgotten. In documentation, everybody will be talking about demand as one of the core pillars that drives the vaccination programs. When it comes to programming, when it comes to implementation, less attention is usually paid to it. So we thank our colleagues from the Sabin Institute for a well thought through discussion on how to drive practice-based experiences in achieving successful interventions for vaccination programs. So each of the panelists will be given 10 minutes to make a presentation, and I will start with the Carla Toko. As I said, Carla Toko is a senior manager in charge of Advocacy and Communications at VillageReach in DRC. Her presentation will mainly be based on insights on how best we look at integration and integrating COVID-19 into routine immunization. She's a social and behavior change communication expert, and we hope that we should be able to leverage on her expertise to be able to provide insights to us on how best we can be able to look at integration, look at a deep understanding of integration of COVID-19 into routine. She's based in DRC, and we are also aware that she has been involved in the previous outbreaks, including COVID-19 and the Ebola outbreak in 2018. So she has rich experience when it comes to social and behavior change communication, and of course also communication during emergencies or during public health emergencies of concern within the African continent. So you're welcome. Come and make a presentation to us.
Thank you so much. Good morning, everyone. And I'd just like to also thank the organizers for this opportunity to present our work, and just like to acknowledge also all my colleagues whose name appear on this slide. I'm not sure how we're going to move, so should we just say next slide? Oh, this one? Okay. How does it work? I should point there. Okay, great. Thank you. So I'd just like to start with a little story about Victor and his mother. And as you can see in this photo, both are getting vaccinated. So Pamela recently gave birth to Victor. And as both left the hospital where she gave birth, Victor did not receive any of the vaccine that any newborn should receive. And a few weeks later, as Pamela was doing household work, she overheard a community health worker who was providing a lot of messages in her neighborhood about COVID-19 vaccination for adults, but also free vaccination that is provided to children. And so that really got her interest. And she went out to meet that community health worker who later came to her house, and they started discussing about vaccination. And eventually that led to an appointment in which Pamela was able to go to one of the health facilities where we did integration work, so she could receive, so that Victor could receive the much needed vaccine, as we saw him getting polio vaccine. And so at the same time, the community health worker also spoke to her about COVID-19 vaccination, and it was the same thing also for the health workers who were able to, that she met at that primary healthcare facility, and she equally accepted to get vaccinated. So that's just a little example of the integration work that we were able to do. But to provide some context for DRC, so as many countries, in the initial rollout of the vaccine, coverage was very low. And what VillageReach did to support the government was to help open a vaccination site in public areas. And this was mostly because in the initial rollout, most people, according to surveys that were done, did not know where to get vaccinated. And so besides just the initial setup of the specific clinics that were providing immunization, but for us to really bring vaccination closer to the population, we decided to open sites in public areas. And there were 4 of them that we opened over time. And towards the last stages of us operating those sites, that's when we did integration. And as it relates to routine immunization, as we heard in the keynote, many countries have a great number of zero-dose children, including DRC, which is really among those 10 countries that have a large number of zero-dose children. And so what did our immunization or integration work look like? So what we really did is take the best practices in running the vaccinodrome and applying it to routine immunization. So as we said, we initially began in public areas, what we call vaccinodrome, high volume vaccination sites, and eventually we transitioned them to primary healthcare facilities. And so in doing that, we still kept a lot of our strategies for fixed site vaccination, but outreach was also one great strategy that we used, because it was not just enough to set fixed sites vaccination, but we really had to further bring that vaccination service closer to our communities. And so, based on, again, the vaccinodrome work, where we would offer vaccination every day, we applied the same thing to those primary healthcare facilities. And the tool that we will highlight, that we're highlighting here, did not provide COVID-19 vaccination at all, but it rather provided routine. So it was really adding that service on to what they were already providing. And as it came to routine immunization, instead of just offering 2 days a week, what we did was increase the availability of the services to make sure that we wouldn't miss out on any children in case they would, at any time that they would show up. And there were also some additional changes that we had to make just to make sure that there would be, we wouldn't miss out on any person, whether they were referred to one service or another. And especially as it comes to routine immunization, when we're thinking about parents, especially women coming to those health facilities to vaccinate their children, we made sure that where we would provide COVID-19 vaccination, if they were referred to that service, that it would be very close to the area where we're providing routine immunization, so that we wouldn't miss out on them. Because sometimes we miss out on people when they referred to another service. And when it came to outreach, I would say that community health workers played a really big role in this, as they helped teams also decide on which areas we could conduct our outreach. And the same thing with a lot of the door-to-door strategies. So this was really community health worker going to household, helping us also identify vaccine-eligible individual, and that's both for COVID-19, but also identifying zero-dose and under-immunized children. So in essence, really our integration work was, how do we make sure that all the resources that we had for COVID would greatly benefit routine immunization, and that's both in terms of human resources, but also financial resources. And so this is really just an overview of what we were able to have as results. I'm not gonna spend too much time here, because this just provides the overall results we have, where in terms of COVID-19 vaccination, our work really contributed to about 33% of all the vaccine administered for that period of time in Kinshasa. And we also did some rapid appraisal of the integration, just to know how it helped us, whether it helped us to maintain actually the same level that we had. And so just using data and also some key informant interview, what we saw is that we really were able to maintain vaccination for COVID-19 in both the sites. So we had one in Gili and one in Masina, who were really in different contexts. So this data is just showing really pre-integration and post-integration that some of the level of vaccination remained pretty much the same, even though at some parts towards the end we were reducing the number of outreach teams that we had. And in terms of referral, as I said, community health workers played a great role. So we were able to also track how many people were referred to vaccination by community health workers, and we saw that, again, depending on the context of either sites, in Masina, for example, community health workers referred slightly more than Gili. And also outreach was really key in us in getting the number of vaccinated that we did. And so, as I said, community health workers played a great role in this integration work. So mainly what I would like to highlight is the fact that they helped us identify close to 1,000 under-immunized children, which was really a big number, considering some of the challenges they had even in going house to house to be able to discuss with parents, and also really finding ways of identifying these children. But in the key informant interviews with the staff, what we saw is that there was some strong acceptance and also adoption of the approach. Again, how best to use lesson learned from the staff who were committed initially only for COVID, and how they were able to really transfer those skills to the health workers who were at the primary healthcare facility to improve vaccination overall in those sites. And also what we also saw is that integration also was a way to promote community trust in vaccines. And then just to end this with, ways, what are some of the enablers of successful integration? I can't stress enough the contribution of community health workers. They know their communities, and they know what are the key messages that can really translate to the community in order to increase vaccine adherence. And also the fact that, as I said, both sites were very in different contexts, and so speaking with those community health workers also helped us to adapt specific strategies for each of those sites, but also providing convenient access. Outreach, we didn't only remain in the same areas where we would do outreach, so it really was spread out from one week and from one day to another. But also investing in data management. So it was very important for us to have daily data that will also help us make some key decisions, and not just in terms of vaccination number, but also in terms of the work that community health workers were doing. But also funding was really important. As it was said, all the funding that we were able to receive for COVID was very important for us in improving routine immunization. And I'd just like to end with this picture, which actually shows the second site in Mycena and how we were able to organize the site. So on the right side, you could see where adults are being vaccinated for COVID, and on the left is actually where routine immunization occurs. And that's just a pregnant lady who came to be vaccinated. So, initially both services were apart. But again, as I said, so that we'll make sure that everyone was in the same area. This is one site in which we were able to rehabilitate so that we can keep both services together. Thank you.
Thank you, Toko, for that presentation and for trying to keeping the time. I request you to take note of the key issues. We shall have a session where you'll be given an opportunity to ask as many questions as possible. So utilize each and every opportunity to put down the key issues or concerns that you may be having. Our next presentation is from Yatender Singh, and Yatender is a seasoned development professional with more than 2 decades of experience in managing nutrition, health, and WASH projects. And his will be a deep dive into how we'll leverage on community action groups to address the impact of COVID-19 on routine immunization. Yatender Singh, you're most welcome.
So good morning, everyone. My name is Yatender. I'm working with Project Concern International, PCI, India, as a program manager. So my program presentation title is Rebounding the Routine Nation Coverage, Slowed Down by the COVID-19 Pandemic, How the Community Action Group Came Forward and Turned the Tide in Uttar Pradesh, India. I would also like to thank my colleagues who have been work for this presentation, and they are here. And please join me for during or after the session if anything I missed. So, what happened? So this is our program geography. Project Concern International India has been a prominent member of Core Group Partners Project Consortium in India since 2001 and works in 22 blocks or sub-district in 5 polio high-risk districts of Western Uttar Pradesh. CGPP aims to mobilize the community to increase the acceptance and intake of polio vaccine in the target area and to sustain the government-run routine immunization program in the catchment area. CGPP works in 15 districts and 3 states in India with 3 consortium partners, which is ADRA, CRS, and PCI India. What happened? I think there is a problem something. Okay. So if we are talking about the project profile and human resources, we are covering. Just click this one. This one. Yeah. Forward. Okay. Thank you. So if we are talking about the project reach, we are covering 173 so health sub-centers, and we are covering 587 high-risk or high-priority area, or community or village. And through this, we are reaching 1.56 million population and about around 35,000 under-1 children in a year. So to support this program, the CGPP PCI deployed the 1 program manager, 4 district mobilization coordinator, and 24 block mobilization coordinator, who supported that the government frontline worker who are the accredited social health activist ASHA. So when the pandemic has occurred, the government reviewing the critically each and every single situation in their respective block or the state level, and with the support of the development partners, they sit together and they strategize the situation and plan and act together, not only for the respond the COVID-19 pandemic, even for the routine immunization coverage. When the lockdown was partially uplifted, then the government has resumed the routine vaccination service in their respective districts. What the CGPP did during this pandemic, we organized formal or informal meeting with the local stakeholders to discuss the issue and develop an action plan to combat these challenges which occurred due to the pandemic. During this period, we provided 12,000 face masks. I'm so sorry, the presentation is 12,000 face masks and 100 dry rations kit to the needy families. We also provide support to the health worker in antigen test and mobilize the community for the COVID appropriate behaviors. The idea to form the community action group to respond to the pandemic, CGPP sought the support from the local stakeholders and used the polio networks when the first lockdown was imposed. So CGPP PCI field functionary contacted the local influencers and they came forward to help the community while even the family member were not helping the COVID-19 victims. They also provide support to the community by providing medicine, dry rations, financial assistance, identification, mobilizing the COVID-19 test, rumor and transportation facility, and psychosocial support in consultation with the CGPP staff. But this was not a structure. Then the idea came into our mind that if the people from the same community are coming together and helping each other, why we can't not utilize this synergy in a systematic approach? Then we formed the community action group, which include the ASHAs, village health, ward members, ration dealers, teachers, local doctor, quack, traditional healers, ex-pradhan, religious leaders, and youth and ex-CMCs, who were earlier the frontline cadre. to the program. And we also ensured that the equal representation should be included from the government side, the Panchayat Raj system side, and of course the community leaders also include this, including the CAG group, so that they can provide the tailor-made solution for this cause locally. What happened when the first lockdown was partially lifted? Around 2.5 million children missed their due vaccine due to the COVID-19 in India. What happened in the CGPP catchment area? Around 59 of the plant, 1,416 plant sessions could not be conducted between April to June 20. And out of that, around 55% plant session could not be held because of lockdown or the area was in containment zone. Only the health facility were open, but the roads were blocked, so people cannot easily access to the basic health services. Also, the fear of COVID-19 infections was on top. The priority of RI was shifted to the next level. So what happened, the pre-pandemic time, the CGPP catchment area, the coverage of OPV0 dose children was 84.5, which reduced to 48.3. The reduction was the minus 36% in the catchment area during the pandemic time. So to cover these children's, we provide the CGP provide the support at various levels. We deployed 264 community mobilizer in the intervention district. We also ensured the support, ensure quality micro planning, ensure support from the stakeholders, PRIs, and the religious leaders, networking and coordination, capacity building of the frontline cadre, provide virtual support to the RA session site during the pandemic. We formed the CAG member and we identified around 2,158 CAG members, including the male and female both, and we trained them on the importance of routine immunization, CAB or other vaccination, basic vaccination, in the 5 districts, in intervention districts. So after receiving the training, CAG started reviewing the field situation for their respective areas and discussed the status of immunization with the community and under the guidance of the CGPP field staff and the BMCs, who is the block in charge for these blocks. They also support the CGP field functionary in conducting the various social mobilization and communication activities such as the community meetings, the information booth, the e-rickshaw rallies, and they also ensure the announcement from the mosque and temples. They also visited the vaccine hesitant family in their catchment area and mobilized them for the routine vaccination coverage. At the RI session, they also support to the health worker to maintaining the COVID appropriate behaviors. Not only that, they also conducted various meetings within the community action group members or with the community as well. So they discuss in this meeting, they discuss the local challenges, they provide the tailor-made solution locally, and they disseminate the key action plan and the planning and the action to the by using the social media, WhatsApp group, so for the wider disseminate there, so that other can also benefit it and draw their influence to act for their own community. When the lockdown was lifted, they also tried to regain the trust for the RI services in the community. CAG member ensured the sanitation and hygiene at the RI session site before conducting the routine vaccination. As we discussed earlier, that apprehension for COVID infection was high. So also they support the COVID appropriate behavior at the session site. The CGPP PCI also developed and distributed the IC material and distributed to the between the CAG member and ASHAs. The CAG member also supported in communication activities, and by this the CAG member conducted around 5,000 community meetings. They reached and mobilized around 1,400 vaccine hesitant family in the catchment area, and intervention reached at least once to all the target population. Now, earlier during the pandemic, the OPV coverage was declined to 48.3. After this intervention, the OPV coverage were gradually increased, and by the end of March 2023, it went up to 74.9%. However, there is a scope to reach the optimal, and around 4,832 RI sessions were supported by the CAG members and the CGPP field functionary. So, CAG members were done lot of great job for their community, but they were not paid by the program or the government. So it is necessary to keep their momentum high. The PCI organized the various PCI organized the appreciation events for time to time to keep their motivation high. And by the end of this project, we felicitate all the CAG members at the district level, where the district government, district officials and partner will felicitate for this support that they provided to the program. Thank you very much.
Thank you, Mr. Singh. Communities usually have so many problems. My question, which you can just note down for you to respond to later. The community action groups. There are so many problems that usually communities are faced with. And I was wondering, beyond immunization or vaccination programs in the 5 districts, what motivates these community action groups to continue working together? Do they also address other health issues? How do they look at other determinants of health in communities? Because all these synergize each other. Do we also see possibilities of using community action groups to address other health challenges in the 5 districts later, at the time when you should be able to respond? Earlier on in our opening session, there were some good insights on how health workers or service providers are usually forgotten in our programming for vaccination programs. Many times they are the receiving end. So they are very central in creating demand, because mainly communities listen to health workers or caregivers much more than any other source of information. So we are going to look into some of the key issues from the caregivers and how we can heavily rely on caregivers in advancing routine immunization. And that presentation will be given by Mr. Muhammad Zia. Mr. Muhammad Zia is a development professional from Pakistan. Zia, you're welcome to make your presentation.
Thank you, everyone, for joining me in this presentation. My good name is Muhammad Zia Muneer, and I'm from Pakistan, working at IAD Pakistan as a manager in the maternal and child health programs. So I will be presenting on the topic related to the caregivers' concerns and queries, which was reported by the caregivers through an immunization helpline. I will be presenting the analysis and some of the key insights from the Provincial helpline data for the last 4 years. So understanding the immunization landscape in Pakistan is important, as most of the audience here is internationals. So Pakistan is, if you see the map, Pakistan is divided into 4 regions, which has different, immunization coverage for the children. So Punjab region has the highest proportion of immunization coverage, followed by Gilgit-Baltistan, KPK, Khyber Pakhtunkhwa, Sindh, and in the end, Balochistan has the lowest proportion of children immunization of coverage, child coverage. Globally, if you see the 1 out of 5 children lack access to essential immunization. However, this proportion is poor in Pakistan if you compare it with the global averages. So in Pakistan, it's 2 out of 5 children are non-immunized. So what are the demand side immunization related challenges and how those challenges made a case for the immunization helpline? So we have seen in the literature in a number of discussions that we already was having in the first keynote speaking session. There is lack of awareness, lack of awareness about immunization related knowledge to the general audience. And then there is also a phenomena from the caregiver end that they basically do not vaccinate their children on time. Third, there are logistical and financial challenges in accessing immunization clinics or immunization sites. Then there are misinformation about vaccine side effects, whether it's health related or non-health related. And of course, that translates into a bigger problem of vaccine hesitancy. Now, these demand-side immunization-related challenges made a case for development of an immunization helpline, which basically we started it, and that provides the accurate information and guidance from the trained health resource to the caregivers who are making phone calls to the immunization helpline. So basically, at IID, we have been implementing this Safe Life electronic immunization registry across Pakistan. And we started this thing from Singh region. So why this is important to show here is because whenever a child is enrolled into this registry, electronic immunization registry, the child is issued a unique identifier, unique QR code. And that QR code contains a unique ID as well as the immunization helpline number. So that's pasted on the EPI card of the child. And whenever a caregiver wants to make a call on the helpline, that phone number is basically communicated through that unique identifier whenever a child is enrolled into this electronic immunization registry. So we started from Sindh district. It was later scaled up to the different regions of Pakistan. So by end of last month, so there are more than 8.8 unique children enrolled into this registry. More than 3 million women are enrolled for the tetanus vaccine, TT vaccines. Whereas more than 104 million immunization events have been recorded. By immunization events, it means if a child is visiting for OPV and BCG, so that counts as 2 events. So each and every single event is counted on a real-time basis with all the essential variables. So more than 4,000 vaccinators are part of this program from both public and private sites. And more than 2,000 vaccination centers are basically utilizing this Android-based application, which is Safe Life Electronic Immunization Registry. So the objectives of this presentation is the 2 primary objectives is exploring the types of demand-side concerns and queries faced by caregivers related to childhood immunization, and exploring the engagement levels and feasibility of an immunization helpline in a low and middle income country, which is Pakistan. So the methodology is it's a free immunization helpline for caregivers. It was set up and linked with ZMEIR, which is Safe Life Electronic Immunization Registry. We provided daily helpline support to caregivers during the working hours in both a national language and a regional language. So helpline data was extracted for the last 4 years, starting from Jan 1st, 2019 till end of December last year, 2022, from the call logs, which is maintained by the helpline operators. That contains all the essential information about the reasons of the call and who was calling. So these are the main results. It's basically the types of reported caregivers queries. So if you see that we have received 94,355 phone calls during the last 4 years. So during the last 4 years, 6.5, more than 6.5 million children were enrolled, and more than 78 million immunization events were recorded. So on the y-axis, primary y-axis, it shows the number of reported queries by the caregivers. On the secondary y-axis, it shows the percentage of reported queries, whereas on the x-axis, that shows the various concerns which was basically communicated by the caregivers to the helpline operators. So starting from the top, so one of the things is very clear from the slide is most of the calls were related to the confirmation of vaccination due dates, like when my child vaccination is due. So that was mainly the calls were from that particular query, followed by location and timing of the immunization sites. Like it was also discussed earlier that social mobility, or people move from one place to another and they don't know where the immunization site is located if they are not in their particular area during the time when the child vaccination is due. So they also ask about that, followed by other various reasons which were proportionally, that was small, but that was important to note here, like query on the vaccinatory strike and date. Like in developing countries, especially in Pakistan, vaccinators, government vaccinators go on strikes due to reasons like low wages and extra workload and all, and that basically increases the burden on the caregivers. Like they visit the immunization site and immunization site is closed because vaccinator is on strike. So they made a phone call to ask when that strike is going to end. And then if a child is ill, child has fever, they basically ask whether they could delay it or not. And there are other various reasons. So key takeaways is 3 out of each 5 calls were related to the confirmation of vaccine due dates, and 1 out of 4 calls was related to the timing or the location of the immunization site. So this slide shows the engagement levels and acceptability of an immunization helpline in the province of Singh. So panel A shows the percentage change in enrollments versus phone calls by the caregivers. The percentage increase in the 4 years as far as child enrollments were concerned was 55%, whereas the number of phone calls were almost doubled. On average, the child enrollments increase by 14% on average each year, whereas the number of phone calls on average increases by 23%, which basically shows there is higher engagement level and acceptability of immunization helpline. However, panel B shows that this service is mostly used by the caregivers who are living in the urban districts rather than in the rural districts. So like 3 out of each 4 calls were coming from the urban districts. So conclusion, like more than 50% of the queries were trivial, and that could basically improve the immunization coverage. Like it's a low-hanging fruit that doesn't require any any science. The second is acceptability of immunization helpline support in low and middle income country. And that is again, this is something which we are sharing, like how many queries were reported, but it's still in the scientific community we have to have a rigorous research designs to see whether that's really has made an impact on the immunization coverage and other primary immunization-related indicators to design a demand-side policy measures from the policy perspective and the government perspective. So yeah, thank you.
Thank you, Muhammad, for a detailed dive into the caregivers' concerns. But if you have been in the sector for some time, you realize that caregivers will always have issues, especially on issues of immunization. I was wondering, based on your presentation, that supposing you have a helpline for immunization services in a country or a district or province, and we know that we have as many health issues or concerns or challenges in our countries, say on average 30 of them. Shall we be having 30 helplines in our districts to enable people to be able to call through and get? I'm looking at the sustainability model of having health-specific helplines for us to be able to reach out and respond to. It is something you can think about and maybe respond later as we get questions from our participants here. Our next participant is Thomas Mavuto. Thomas will take us through, we have had discussions about the zero doors and the impact of COVID-19 on this issue since 2020. Thomas will take us through how to leverage on community structures to be able to mitigate this challenge. Thomas works with the Ministry of Health in Malawi as the Acting Deputy Director of Preventive Health Services and substantively as the Chief Health Promotion Officer. He's also the chairperson of the Public Health Risk Communication and Community Engagement Committee of Practice for Africa CDC. It's a steering committee that was formed to take up public health, risk communication, and community engagement, community of practice issues on the African continent. Thomas, you're welcome. Kindly come and make your presentation, give us insights, how the community structures supported stabilizing immunization interventions in your country.
Thanks so much, Richard. Good morning. Good morning. I was thinking about maybe it's the time difference, the jet lags, but we are just too quiet. All right. Thanks so much, Richard, for giving me this opportunity to do a presentation. I was wondering if the chair is asking a lot of questions, what will happen to the audience? I hope you still have my question before I start presenting. All right. So as he has pointed out, I'm Mavuto Thomas. I work with the Ministry of Health in Malawi. We had a practical implementation experience in terms of reaching out to zero-dose children. So I'll just give a snapshot, and I expect that we do interaction further after the presentation. So this was a prospective COVID-19 recovery strategic proposal, which we implemented. And this was followed up by an immunization fellowship program, which was organized by WHO and the Boost community. And for your information, I would like to invite you to join the Boost community. There will be a booth somewhere there so that you can be able to interact with people that are working in immunization. This was funded by Sabine Vaccine Institute for implementation, and the implementation was from October to February 2023. You agree with me? I think the morning session, people have talked about the COVID-19, how it has affected various health services, including the immunization services. Parents were not coming with their children for fear of getting COVID. The health workers, the ones that we are expecting to vaccinate, were busy responding to COVID-19 situation in various countries. You agree with me, the issues of to do with misinformation, disinformation, up to the extent that WHO come up with a new term for dealing with information and misinformation. Do we know it? The infodemic. So the infodemic also affected not only COVID-19, we're talking about the life course immunization. Everything that we're doing, I think people are relating to COVID-19. So the immunization services were also greatly affected on the same. You agree with me, maybe before COVID, we have now seen the emergence of vaccine-preventable diseases. If you look at the southern part of Africa, we are talking about the polio outbreak, the measles outbreak, and other outbreaks that are coming in that before COVID, they were not there. So what is it that is happening? That's what we try to explore. Just to emphasize that when you talk about the zero-dose children, these are, I think Gupta talked about this, I don't have to repeat, but we are talking about the first, the children that are lacking the first dose of DPT, and these children are more likely to become sick and die from COVID-19, from vaccine-preventable diseases. And just to give you a practical example, last year in Malawi, we reported a single case of polio vaccine, of polio outbreak, a single case of polio. And looking at this case, she had only received, this is a 3-year-old, she had only received a single dose of OPV, only. And that's why she was prone to the disease. And just to emphasize that it is important because globally, about 14 million people are labeled as zero dose. And if they accumulate, I think this makes us as a challenge in terms of having the vaccine-preventable diseases. For some people that have, just to give a highlight in terms of Malawi, is Southern Africa. It has got a 19.6 million people. And the study was, the experience was happening in one of the health facilities in one of the districts in Malawi, which is called Doa, and the health facility was Ntengwantenga Hospital, and it has got a total population of 54,777, and in terms of the under 5 children, it's about 9,000, and under 2 children, around 3,000. The overall goal of the project was to ensure that we reduce the zero-dose children by 90% by February this year, and also to identify and map the characteristics. We really need to understand who are these people, who are the guardians, in terms of the locations of the zero-dose children, and identifying is just one thing. We really need to reach these children with the essential vaccinations. That was our second objective. And also just to monitor the progress in terms of how best can we sustain the activities. Some of the activities that were implemented, we have to do an interim meeting with the health facility staff. They have to understand whatever is happening, why we are doing this. And also we had a data review in terms of the immunization services, in terms of the coverage. Of course, going beyond the coverages. Somebody talked in the morning that we are more focused on the coverages, but we have to go beyond that. We also had engagement meeting with the community and faith leaders. These are the gatekeepers. They have to understand what will be happening in their communities. So we had a door-to-door mobilization and the mapping of the zero-dose children, and also went further than that, doing data analysis. So the household with under 2 children was mapped just to check in terms of the immunization status of the children in that particular household. To check whether we have zero-dose children, to check, we went further apart from that, and just to look at if there are any other children within that who have maybe missed an antigen or 2, also to map them out. And after the data analysis, we had to go back and do the supplementary immunization services in order to reach out to those children now with one, if they didn't have any vaccination, to reach out with the vaccinations. If they are missing out other antigens, we have also to go back and do that. We had a review meeting because what we want at the end of the day is the health center staff to continuously monitor in terms of the zero-dose children in the particular locations. And we had dissemination of results. We also had monthly calls with the mentor. And as we are implementing the project, we had some challenges. The COVID-19 as well as the outbreak, which I talked about. This also affected partly in terms of the health workers that we are relying on, the community-based health workers, because they are also responding to the to various outbreaks. And also, we implemented this in the rain season. We managed to map out some children, which eventually, when we're coming up with the supplementary activities, we find out that some parents and guardians have moved to other areas for farming. So what have been the results? Looking at the mapping data, about 1,700 households were mapped, and from this, we managed to come up with 165 children that were mapped. And out of this, 133 and 32 were zero dose and also missed children. And out of those that are identified, we managed to reach out to, from 165, we managed to reach out to 159 children. And we gave them the various antigens that were missing. And for those zero dose children, we have started, we also started and ensuring that they completed their immunization according to the schedule. We used the existing health workers, the community health workers, so that we should be able to ensure that they continue with the exercise as we are moving on. The intention was to ensure that there should be a continuity of routine immunization activities despite the COVID-19 pandemic, despite other outbreaks that are coming. This just gives us a snapshot in terms of the number of households that were sampled, the zero-dose children, as well as the missing children. And this just gives us a snapshot in terms of the, out of the children that were mapped and those that were reached. So just to look at what have we learned now from the experience that we had. Practically, I think what we need is to ensure that continuity of services despite the COVID-19, despite the future pandemics, despite the future outbreaks. We really need to ensure that the health services, including the immunization services, we are talking about the life course immunization, should be part and parcel. We should be able to build resilient systems whereby we should be able to ensure that our children are reached with various preventable vaccinations so that we protect our children from various preventable diseases. The coverages are not enough, but in terms of how are we reaching out to our children for them to get protected. The use of local health workers in terms of problem identification and coming up with solution and also to implement that particular solution ensures that sustainability should be part and parcel of the solution. I'm being reminded of a time. All right, so just to few recommendations. Mapping should be done maybe across all the country because this was a small scale, but we really need to go beyond the mapping of the zero-dose children. And for your information, our country is now developing the zero-dose strategy. And we have also to build capacity of health workers in identifying the zero-dose children and how best we can be able to reach them. In terms of the building upon this project, the findings will help in terms of inputting into the zero-dose strategy that is being developed by the EPI program, the immunization program that is currently being developed in the country. And the health facility team, as a matter of sustainability, has put in place plans whereby each HSA is a community health worker. We ensure continued mapping of zero-dose children in areas being done through the door-to-door mobilization and active follow-up of missed children. We have to acknowledge the Sabine Vaccine Institute for the funding, the WHO, the Boost community, our district health office, the hospital team, and also my mentor, Karen Wickings. Thanks so much for your attention.
Thank you, Thomas, for that presentation. I will also ask you, I see you tried to threaten me to avoid my questions, but from a strategic implementation point of view, based on the findings and your recommendations, do you think, how best do you think this study can add value to the advancement of implementation of routine immunization in your country, given the fact that this was a small-scale study in one district? Scaling up means so many, putting into consideration so many issues. So I just wanted to think through that. Our last presentation, I see we are trying to manage time very well. By 12:45, we should be warming up for lunch, and we should be out of this place. Our last presentation is from Dr. Sangui, who is a public health physician and researcher with extensive experience in healthcare access and community health system strengthening in low-resource settings. Most public health physicians don't pay attention to community health systems. It's good that we have you here. So Dr. Sangui, kindly come and take us through your presentation. We need to look at how best we can contextualize intervention design, look at the different cultures from different communities in advancement of immunization. You're welcome.
Hello, everyone. Last presentations are always complicated, but at least thank God this is not Zoom. So at least I get to see whether my audience is sleeping or not. Yeah, but in preparing it, I was well aware, so I'll keep it really short. Am I doing this right? This one, okay. All right, so to keep it short, this model, community-oriented primary care model, is known, right? But then I wanted to demonstrate how we can use this to develop like an integrated package, you know, in delivering our vaccination services. So we talk a little bit about the case for action, the approach in generating vaccine demand, and then the intervention and the result. So here, of course, this was done in Cameroon, but the background of the country and so on is not really necessary for this presentation, so we'll go straight to the community. So you have a community where 91.7%, of the children are zero dose. So to speak, every child there is a zero dose child. It's not like government and partners and other agencies have not been vaccinating. They have been doing these sessions, but only that it happens when fundings are available. So this study happened to be carried out during a period where there was a lapse in funding, and so you had an entire district made up of zero-dose children. And this called to mind the idea of thinking more, a little bit more about sustainability, as much as it's important that we use campaigns to to catch up where there are no hesitancy. It's important to look for sustainable solutions to avoid, things like this. So I'll go straight to the model. So you have the community-oriented primary healthcare cycle. The first thing has to do with community diagnosis. In vaccinating children, it is important to know the community we are dealing with, right? And to do that, we need to come up with a diagnosis. This is the only way for us to be human-centered in whatever we're doing. And coming up with a diagnosis means identifying clearly the population we're talking about, knowing what they consider as their own needs, right? Before looking at the quantitative data that we have at the district, let us find out from them what exactly their health needs are. There will be quite many, so we will need to prioritize, and to prioritize, we have to be objective. It doesn't have to be based on maybe because I'm a malaria expert, so I think that since there may be some cases of malaria, the malaria has to figure out as a key issue. So it has to be really objective. After identifying the problems, we need to do some detailed assessment, and then you have intervention planning, implementation, evaluation, reassessment, and then the cycle continues again. So this is the best approach to develop that. But to do this, we have to be conscious of the fact that a system has many components, right? So the WHO health system pillars has to act like a guide, because no matter what you do, if you don't consider the leadership and governance, if you don't consider human resource, the financing, service delivery, communication, and so on, it is still going to fail. So you have to take all this into consideration in coming up with your design. So talking about community diagnosis, this is a typical community which you will find in most low and middle income countries. No matter how the country is developed, you must find a community like this. It could be an urban slum or something. So you realize that these people, their problem is beyond just saying we want vaccines, right? When you do a qualitative study here, they know what vaccines are. They understand that this is useful. It is just not a priority for them, right? So it is important to carry out this kind of observation and qualitative study to understand what their problems are. This is climate change messing up an entire community, where the first image there, you have people transporting their houses. So because of flood, they had to transport their houses behind. This has impact on access to vaccines, because to get a good last mile distribution in this kind of setting is very complicated, right? They have issues with waterborne diseases. The last picture there, that's a well. And they practice open defecation in this space. So when you have flood, it washes through the community into this well, and then the result is that's a cholera epidemic. And then there is cholera epidemic, and there is no health facility. So they're hanging outside to receive care. So when you come to this kind of community, there is a problem of nutrition and so on, and you present COVID-19 vaccines. What exactly do we really expect as a reaction? They should refuse. If I grow up in this place, I'll throw stones, right? So this is the whole idea. We have to do this kind of community diagnosis to understand our community, first of all, prioritize and accept that they have a problem, help them to solve that problem, while using the huge resources, the millions of US dollars that we have for vaccine delivery, to also strengthen this community delivery system. This is the entire idea. So to do this, to prioritize, because they'll have 1,001 problems, we start by developing an objective scoring system, and then collecting the data for computing. The scoring system is completely dependent on you, the team, and maybe the community, right? Everybody could develop their own kind of scoring system, but the whole idea of having a scoring system is to absolve yourself of that responsibility of thinking that you have to decide for people. If you have an objective guideline, you no longer need to think for them. You simply use that guideline, and then you have the outcome. This is an example there which we did we picked up a few communities in this district and we established. So we consider district priority. We had 5 indicators. We consider district priority to be a factor, which means that we needed to look at data and also get feedback from the district what they considered as a priority. This is important because you also want the buy-in of the district. If you do not include the things which the district or the government considers as important and you focus only on the community, you also have a problem of sustainability because the district would not be interested in what you're doing. So we needed to add this component. Then there was an issue of community health involvement. If we are dealing with communities that are quite far, there are no health facilities, we need to think about how community health workers sustainably get involved in this system. You have cultural acceptability. You don't bring in, there is a community there that don't take injectable medications. So how are you going to issue measles vaccines and so on? So this is something that we had to take into consideration. You have impact on vulnerable population and so on and so forth. So if you have your own scoring system, whichever one which you choose to use, your indicators that you decide, there is no right, there's no wrong priority, but you need this system to absolve yourself the right to choose for people. The next thing will be to set up an inclusive dialogue structure with feedback mechanism. For countries, for instance, Cameroon, this exists, but most or some districts don't practice this because people need feedback. They need a space where they can say we are not okay with this and then get an appropriate feedback. And this is usually possible through a dialogue structure in which you have an inclusive team from the community, religious representatives, teachers, and so on and so forth, in which they meet with the health district, you know, in a common ground and have an open discussions from time to time, have meetings, so there's some sense of accountability. So you need to have this. It could be different for your own setting, but there should be a feedback mechanism. We need to leverage inclusive dialogue structures to sample opinions on health needs. So we need to leverage this kind of dialogue structures to then find out from them what they consider to be a pressing need for them. And this has to be scored in a way that it is somehow representative of the population we are serving, which means that the composition of the dialogue structure must be inclusive, people living with disability and so on and so forth, men and women alike. And then we consider health district priorities, which I've mentioned, because if you neglect that, they will not support you and there will be a problem of sustainability. And lastly, when you have your result, you have to discuss with them, community, the stakeholders, and validate and accept that, yes, these are the priorities we are going to take into consideration. And then considering that these are the resources that we have, we will prefer to focus on this. So when we have done this, the next step now is to do a detailed assessment. This detailed assessment looks at the problems identified to be the community needs, and then it also looks at the vaccine issue, right? So that you have perspective on the vaccine issue and you have perspective on other primary healthcare services. For instance, in our setting, we realized that, first of all, the district was a hard-to-reach district. It had just one health facility, and then you have a district with over 47 isolates, right? So it is practically impossible to say just because someone wants to vaccinate the child, they'll leave over 50 kilometers away, bought a fishing boat, you know, to spend hours on water just to cross to the district to get the vaccine. So this is a practical problem because that time could be used for fishing or other economic issues to solve their nutrition issue. And that's why the vaccine is not a priority. We also found the issue of dunar floods. You move into the community, it's all dry, right? You see where these guys are standing? It's dry. And then suddenly you get up and you see water everywhere, up to the extent that you may need a boat, you know, to get there. And this happens twice a day. So these are practical difficulties that we found. There are many other issues like insufficient community health workers, lack of proper community engagement, and so on. But also, interestingly, reasons for vaccination hesitancy Okay, I thought he was warning me about the time because I was enjoying the presentation. All right. So, so we also found that there was preference for hospital-based vaccination to home-based. So the fear is when you vaccinate my child at home during campaigns, you leave, and I stay back to suffer with my child. There is no hospital for me to, go to say, my child had this problem. So that's why they refuse the vaccine. And this makes sense, right? So these are some of the things the insights that we can get from doing this kind of assessment. So it is based on this that we came up with a simple package for community health workers that focused on caring for pregnant women, children under 5 having malaria or diarrhea diseases. So we developed a simple community health worker package that, of course, in Cameroon, community health workers don't vaccinate, but they refer, right? So in the first month, referral, you send people, they were not going, they were not accepting, but over a pace of 6 months, referral increased to about 40%. So which means they referred 268 children, and then they succeeded to vaccinate 118. This shows that there is some progress that can be made. It is true this study has some limitation in terms of the size and so on, but we think that this is something that could be leveraged. So to vaccinate zero-dose children in mixed communities, it requires integrative approaches that prioritize local health needs based on the community perspectives, not our own perspective. This is important. Thank you very much.
Dr. Sango, I was in Cameroon. I saw how you guys love your country. I knew you would take a minute extra trying to explain to us the components of community diagnosis. Thank you so much for the presentation. I don't know whether you have had an opportunity to look at some of the theoretical perspectives that lead to or that guide demand creation initiatives. And I wanted to ask that how can we leverage on the community diagnosis processes to set the agenda for routine immunization, given the fact that if you visit a community or village called Kabanda, the challenges and problems will be enormous. But as a public health expert, your interest would be to focus on immunization, despite the fact that communities have other challenges. So how best can you look at the entire process to be able to discuss prioritizing immunization as one of the components for as setting the agenda for immunization programs in that community? So we have had all the presentations, and it looks like it is only Toko whom I didn't ask, maybe because she's a female. I don't want men to complain, but let me ask you a question, Toko. In your presentation, you did talk about some enablers. And I was wondering, how best can we look at these enablers to be able to increase demand for new vaccines? COVID-19 vaccination program, of course, these were new vaccines. You know that many researchers working day and night to ensure that we have vaccines for EVD, for Ebola virus disease. And DRC is prone to EVD. So how best can we look at these enablers to be able to think through, to leverage on these enablers to increase demand for new vaccines? It may even be a new vaccine introduction in your country for these other vaccine-preventable diseases. So, colleagues, you have heard from all the 5 panelists. I will ask them to respond at once. I did ask each of them one question. I don't want them to respond to only my questions. I want to give you an opportunity to ask so that they're able to respond at once. Looks like we have 22 minutes. So if we can have maximum of 10 questions, so each of them will be given 2 minutes or 2.5 minutes to directly respond to the questions. These are experts, so we just need to get insights, practice-based insights on how best we can increase immunization services. The floor is yours. I'm starting from this side, one hand. 1, 2, 3, 4, 5, 6. I don't want to give chance to those who think after people have asked. So I will start from this side, then I will move to this other side. So I've seen 6 hands this side. Can I have a microphone? Okay. It will help you also to exercise.
Hi, I'm Sudipto from PCI India. I have a few questions to speakers. One from Pakistan. I think that's a very good presentation and how you have used these telephone calls to promote the uptake. But one thing, I'm a MLE practitioner, researcher. So my idea was, when I was looking at your data, then you have shown the rise in the enrollment and the rise in the calls. I think we should also include in that model that during this phase between 2019 and other areas, whether any other things happen in the program, so that you just cannot say that because of the rise in calls, because you're not controlling the other effects. So if you have other effects, which is not possible from your data set, but from other context, if you know, then only you can tease out and then attribute to the rise in enrollment thanks to the rise in calls. So this is one I think I should, because if you want to publish it, it is very interesting. It will be a very interesting paper. And I have one question to Thomas about that mapping. I think it's a very good strategy for mapping to identify where are those zero-dose children. But one thing I always grapple with mapping is that, considering the fact, thanks to climate change and other necessities, there's a lot of migration. Even if you map, you know the people are not there, they might come back, seasonality is there. How do you tackle the problem of migration through this mapping exercise? Thank you.
Thank you. So, Madam Timekeeper, make sure that each person has 30 seconds maximum to ask a question.
Okay, thank you. I am Anodi Kaihura from Tanzania. I work with Africa CDC on Africa Union Bingwa Initiative. So I was very interested with most of your presentation, and I think all speakers were good. But I have two questions. One question to Mr. Singh from India. You had a very good presentation on community action groups. But my question remains on your sustainability plan. As you have said that they are not paid and you just do some kind of morale, but how do you ensure that the program will be sustainable and even beyond COVID-19? But also another question to Mr. Thomas. So my question was, do health surveillance assistants paid? Are they the government employees? And because if you are thinking on scaling up at the country level, we need to think of that, or how we finance the health surveillance assistant, and is it cost effective to use? Thank you.
I want to thank the presenters so that we avoid thanking them. Thank you so much for your presentations. The presentations were very good. So whoever will come on the microphone has done the same.
Hi, everyone. My name is Anita. I work for CHAI, and I support our vaccines delivery work in Southeast Asia and Pacific. I think, well, without thanking the panelists, but I think that goes without saying, but I think most of you talked about using community stakeholders, either health workers or other community action group members, to do door-to-door registrations or mapping of zero-dose children. And I was keen to understand what kind of questions do you ask when you do such an exercise? And as a follow-up, like how can we use that information to triangulate and see if the child that we registered actually did receive a vaccination in a follow-up session? Thank
Anita, whom do you want to answer that question?
you. Anyone who wants to answer. I think it was part of many panelists.
So we can as well get somebody responding from the audience.
Sure.
Okay.
I'm actually keen to learn more about community registration practices.
Okay. Two more, are there two? Three more questions from this side. You're perfect. You can come and...
Thank you for the wonderful presentations, and let me congratulate you all for the wonderful outcomes of the programs implemented in the countries. So my questions would go to Mr. Singh. I would like to know if you face any challenges in terms of human resources when you implemented your project in India, and if yes, what were they, and what were your mitigation actions? Thank you.
I want to comfort my panelists. If you are receiving many questions, it is either you were not clear or you were very clear. Or people found out that there is a lot of information that you have, but because of time, you are not able to provide all the information. So we have exhausted this. Can they respond? Then we get to this side. Okay. Let me start. You can actually remain where you are.
Hello. Yeah. So thank you very much. Let me respond first the last question. The challenges faced in India regarding the human resources. So in our program area, definitely in the government system there is some issues with the human resources, but not not many. Ashas, which is the government local frontline cadre, they recruited most of the frontline worker in the systems, and to fill this gap, we introduced this community action group. So they just provide support at the community level. Regarding the sustainability of the CAG, so I can say that they established the CAG member is locally from the same community, and they come with their established credibility, trust, and respect from the community. And the community, so not only this, when we formed the CAG member, we trained them. So they work with the government systems. So they also motivated because they already inspired, because they are not new. They worked earlier, they worked with the polio program. So they know the local situations, the contextual situation from their own community, and they came forward to support their community for this critical situations. So they also motivated, and of course, yes, the motivation is very necessary while we are not paying any monetary support. So the government is appreciating their effort time to time, and what happened, we also incorporate their name in the government micro planning. So when they are visiting, somebody visiting in the primary health centers, so their name is there, the village name and the CAG member name is there. So they feel they're proud, okay, we are doing something in community, and government also recognize our effort. So this is, should I also answer your question?
I'm also a participant.
Sure. So the community resilience, if we are talking about the community resilience, the community is, in India, community is very supportive. Even during this COVID pandemic, they supported each other. Neighbors supported to provide the dry rations, medicine supply, or the milk, because when the lockdown was imposed, nobody can go from the outside. So they just support each other with their possible best way. So this is so the community is helping each other also. The other also the only challenges is the where the gaps. So gap is for the marginalized community in the government system. How we can integrate this section for the government services, and our role is the same role. We are bridging the gap between the demand and services. Thank you. Over.
All right, so I would like to answer the questions raised by my dear colleague from India. I absolutely agree with you, and this was the one of the few points which came in my mind when I was finalizing the presentation, and that's also something which I mentioned in the last slide of conclusion recommendation. There is a need to have a rigorous, evaluation of the impact of such activities on the immunization coverage. And of course, there must be some, since that's, at a different interval of time across 4 years, there is a possibility that some other intervention took place that basically made a rise in the number of phone calls. But this still, the number of phone calls has been rising, and we have never made any, such extra campaigns that basically could lead to the rise in the calls. But again, I agree with you. Once we publish it, or once we go into writing a manuscript, this is something which we need to ensure if there are any counterfactuals or other variables which might be of interest to see. Thank you.
Thomas.
All right. All right. Thanks so much for the question. Hello. Thanks so much for the questions. I think Richard, for your question. Thanks so much for the questions. I think for yours, I think we'll answer each other at a later point. I'm just joking. All right. There was a question in terms of the health surveillance assistants, I think from a colleague from Tanzania. Just to say that the health surveillance assistants in Malawi, they are community health workers employed by government. So they are part and parcel of the health system, but they are basically looking at the community health services. So they are government employees. So ensuring sustainability, they are part and parcel. That's a core duty also to ensure that they are providing the immunization services. In terms of put into perspective people that are migrating, coming in, going out into various areas. So if this mapping is done as a routine, should be a continuous process, should not be a once-off. So we have different tools that we also do in immunization. We are talking about the under 2 registers. We can be able to also to extract information whether people are coming, children are coming to complete their doses. And also, if this is done at a larger scale, wherever these people will be, I think they can be mapped. So this should be a continuous process. And there was a question in terms of what kind of questions do we ask when you're doing the mapping. I think there are a number of them, and just to check whether that household has got under 2 children, whether the children have been receiving the vaccinations or not. And we also have to look at the health profile, the information that the child has, to check. Don't rely on the recall. But if no information is available, we can check the under 2 registers also, and also just to ensure that whatever we're getting is a true reflection from that. But also, the mapping also raised the profile, because people have got questions, and which can these people that are doing the mapping can be able to respond to. And this also will bring in the issues of vaccine confidence, because if you are responding to questions and the importance of that vaccination, I think the parents and guardian can be able to attribute to that as well. In terms of the question from the chair, how do we integrate this into sustainability? Yeah, so as I've mentioned, that the health surveillance assistants, their primary role is to ensure that community health services are being provided, which includes the vaccination. This should be integrated in their routine work. When they're going the households, they should be able to ensure that they're also finding out those people, those children that are missed, those children, and to ensure that they are bringing those people back into the system, back to care, so that they can be vaccinated. I think let me stop here from the question that I had. Thank you.
Thomas, you have talked about integration. This work was sponsored by Sabine. As part of integration in the normal work for the community health assistants, surveillance assistants, something like that. So can't we still scale up and do the mapping using available resources without looking at this project?
Yeah, it's possible, because even in my presentation, I talked about, as a country, we're coming up with a zero-dose strategy. After looking at a number of missed children and also the reimaging of the polio and other things. So as a program on immunization, there is a zero-dose strategy that is being developed. And one of the key components is the mapping that these extension community health workers could be able to do as a routine without any external funding.
That question was sponsored by Sabine. So. Okay, do we have 5 minutes left? I would like to request you to give me more 5 minutes so that we make it 10 minutes. Food will still be there. We can still cope up with lunch so that we have 5 minutes, 4 minutes of asking, and then 4 minutes of responding, and 2 minutes of closing the session. Agreed? Okay, so you have 30 seconds, starting from you, 30 seconds of asking.
Okay, thank you. I am Dr. Meta from Indonesia. I would like, my question will be to Mr. Singh about the community action group. Yeah, how would you do the fundraising? I mean, who are responsible to give operational cost support for the community action group? And about the appreciation event that you gave to medical worker, to the doctor or the medical team that involved in your community action group, what kind of the appreciation is it? Yeah, and about the vaccine acceptance in Cameroon, I have the same. I mean, you said before that they know the benefit. They are not refused to the vaccine, right? They just do not prioritize to accept the vaccine. And in your country, how about the government support? I mean, the reinforcement of the law from the government. Is it good also? And is it stated and vaccination is protected by law or not? Okay, thank you.
Okay, we have the next question, followed by him, followed by him.
Yeah, I'm Sanjay Pandey from the Global Health Advocacy Incubator and based in India. I appreciate panelists as well as the moderator. So it was so nice to conduct this way. So I just have a very small question and very simple question. Did you also included ethics into your practices and have the principle of ethics for the practices? And the second part is, what have you done for the data privacy and the data protection from the community action? So that will be really important on that. Thank you.
You're the only one who has talked about the moderator. Do you have another question? Okay.
Thank you, moderator, again. My name is Saransh Sharma. I'm from Final Mile Consulting. We are a social and behavior change company. All your perspectives were very enriching. My question is for Carla, Yatender, and Thomas. I think all of you spoke about community health workers and their importance in mapping and sensitizing the community. Want to understand, routine immunization, mobilization by community health workers was happening pre-pandemic, and it was happening during pandemic. Of course, a lot of community behaviors and attitudes changed. And what did you have to do in terms of orienting and capacity building of community health workers to really catch up to these changing attitudes and behaviors within the community? Thank you.
One more this side? Okay, you'll be the last one.
Thank you. My name is Yvonne from Knowledge Success, and I'm based in Kenya. My question is to Carla. Thank you so much. You talked about enablers of successful integration and talked about things like maintaining collaboration with community health workers as well as providing adequate funding for staffing. How do we make this more practical for different countries? Because, for example, funding for staffing is very difficult in many cases. We don't have enough healthcare workers, and the funding may not necessarily support all this. So how do we make that practical? In the same way, for collaboration with community health workers, we've seen that they're more used as a channel rather than an audience, so they may not even understand what they're being told to do. So how do we make that more practical? And then my second question is to Sangwe. And you talked about amplifying, how do we amplify community voices in terms of prioritization? Because a lot of the times, the funding that we get already has its own priorities, which may not necessarily align with the community. So how do we raise that voice to get funding for community needs and what the community actually would want? Thank you.
You still have a question, or it has been responded to? Okay, both of you can come so that we save time. 30 seconds maximum.
Thank you very much. Thank you, panel, and moderator also. I am from Somalia country office, work with WHO Somalia. So first question is, I ask you for how community engagement for Singh, how we can engage border community, same community with different countries, because Somali communities, maybe they can cross border Kenya border, and also some community, large communities, they cross the Ethiopian border. So how we can engage that community? Also, my second question is to Muhammad. We need to make immunization registries in Somalia, and also we need to how the effective immunization registry in routine immunization, which challenges and also recommendations. Thank you very much.
Okay, my question is related to community health workers. I know in Malawi you said community health care workers are owned by the government, but in case of Somalia, when the community health care workers are owned by different NGOs that run the health facilities. So, the NGOs are funded-driven projects. So when the fund ceases, the project closes. So making a holistic approach in these community health workers in a community level that can work and be sustained beyond the projects. How we can, in your practice, in your experience, how we can integrate these different community health workers at the community level? Thank you.
I was worried of ending this session early than the time that was allocated. But I'm glad that maybe it is getting interactive. I had closed this side, but when I was growing up, I was told to respect old age because it comes with wisdom.
Thank you very much. And my question is for Clara. My name is Filimona from Core Group Partner Project from Ethiopia. And my question goes to Clara. And maybe you are talking about the integration. This is very important and successful project that you are presented. But when you are said that integration is you work with the community health worker, that is with agitations and other supporters are coming to integrate the COVID vaccine with the routine immunization. How do you comment on the sustainability issues of this? You are always this funded, and you are working community health workers. If the project is stopped, so how we worked on the sustainability issues? The other one is COVID is the life shelf is very short. So how do you comment that one as well, and how this integration is work? Thank you.
Thank you. The very last one. The very last one. You know, women empowerment is now a very big issue. So we have neglected men. Whenever women raise up, so you don't want to leave them behind. You're the last one, madam.
Thank you, Mr. Moderator. You're a great moderator, by the way. My question goes to Carla. I don't know if it's the same Carla that I met in WHO DRC. She was working for VillageReach. So yeah, okay, my question is related to, I mean, I did not follow your presentation, but I saw that you made a presentation on integration. But I know that in a previous life, you were more pushing for vaccinodromes. So you've been to both sides, vaccinodrome, but also integration. So now having both experience, I would like to know from you, what are some of the lessons learned? If there's another pandemic, which way will you push for investment and why? Thank you.
Thank you, my panelists. We don't have time. I want to give you 90 seconds each. Just respond and close. Starting from you.
Hello? Hello, can you hear me?
You can use the other mic.
Okay, thank you. Yeah, I did receive quite a few questions. And maybe I'll start with community health workers. Overall, I'll have to say that, yeah, with COVID, it was very different. You know, we're used to having community health workers bringing messages to parents about vaccinating their children. But with COVID, community health workers themselves were also part of the eligible groups. So in that, we also had to, you know, besides just providing them with information that they had to give to the population, to the communities, we also had to make sure that they themselves were accepting of the vaccination, because it's hard to bring those messages to the community if you yourself is not convinced about the vaccine. So that was really one thing that we had to work with community health workers on. And infodemics was really also a big a big challenge in the vaccine rollout initially, as I presented. So that was part of the capacity building also that we provided to community health workers. One main thing that we did is through their interaction with the community, they faced themselves questions that they had a hard time responding to. And so we actually even organized a workshop where we worked with an infodemic specialist who was able to provide them with ways in which they could respond to those questions. And one thing also that I didn't mention is that for integration work, there was also additional training that was done to make sure that they can provide both messages on COVID-19 and also routine immunization. So really, just to highlight that communication is key, and this is really, but responding to the question from the moderator, Richard, communication is key, and who is communicating is also important. For some vaccines, it's not going to be just community health workers doing that. Again, as we saw during the pandemic, especially with health workers, there was a lot of resistance from health workers themselves. And so it wasn't going to be the community health worker providing answer. It had to be, we had to bring some scientists or other health workers who could provide a specific answer that health workers had. I'm being asked to stop, so maybe I'll answer some other questions during lunch. Thank you.
1 minute.
So thank you very much. And the question regarding the funding. So in CAG, Community Action Group, we don't have funding, even the project or from the government system, but the sustainability, we think something and we are doing in the same direction. Now the CGPP staff, field functionary is supporting, is leading, the community action group in such as the trainings, the meetings, and if they are facing some challenges, the field situation like any communication challenges from the community and how they will deliver the appropriate message. Now the CGPP functionary is helping them. But what happens if the program will be over? So the government frontline cadre, ASHA, has their own supervisors called is ASHA facilitator. So we also invited, while we are conducting the trainings or meetings, the AF is also be a part of this meeting. So the, after that, the ASHA facilitator will lead this process, and all these problems, if they face in future, so government will support in this. Also, the National Health Mission have also their staff at all the levels. So at the community level, the ASHA and ASHA facilitator is working, and the block level is block community process manager is working. So this is responsible for all the ASHAs. He is the supervisor, he or she is the supervisor for the ASHA and ASHA Sanghanis. So time to time, they also visit the field and they meet to the community action group, they discuss about the situation and the action plan. So this is the second line for this sustainability for the CAG members. Regarding the felicitations, so now we are conducting the felicitation event for the community action group, where the district authority or the block development authority is appreciating with the partners. So also they are inviting by the government in the development meetings or like the district task force meeting, the blast task force meeting, and they are listening their challenges, field challenges, and the solutions from them. So they are another motivation to them. Okay, government is listening now our voice. This is another thing. Sorry, you are saying something?
The other one can be responded to as we have lunch.
Okay. So now the last one, the training, and we are also providing the training to the health worker, like the IPC communication skills, also the indigenous tools. So how they can utilize their local tools to solving their local problem in the local settings. So they are sharing the importance of the immunization by using the indigenous tool also. Thank you.
So there was a question from a person from Somalia, so about the challenges which we faced in implementing this immunization helpline. So I would just quickly go through some of the pointers. One was you must ensure that the operators, the helpline operators, they know the local language and different dialects, because people speak different languages and different dialects. Second is about the natural challenge of network issues or network problem, like people are calling from an area where there are no network signals, especially in the low resource settings. The third is please do ensure that the helpline operators have a gender balance. It's comprised of both males and females, because some of the caregivers are reluctant to speak to males or female ones. Last and the most important is you must keep government in loop in implementing such a program, because it deals with immunization, it deals with EPI, it deals with the information related to immunization. So government should also be taken on board while implementing such a program. Thank you.
Thomas, the system tells me it's going to close off. Lights will go off.
All right.
30 seconds.
All right. I think there was a question in terms of the community health workers. Maybe just to say that apart from being government employees, we are also working with volunteers to ensure sustainability within the communities that we are working. They may be changing maybe the government health workers, but the volunteers that we are working with, they are part and parcel of the communities. They are the ones that are helping in terms of providing different services. Yes, I think in terms of the vaccination mobilization, we were there before even COVID, but what we're doing now is these community health workers have to be reoriented in terms of the changing dynamics, landscape that is happening in terms of getting they have to be updated on whatever is happening, and also ensuring that we have a system in terms of getting community feedback, and also that will also help in terms of programming in various immunization services. I think in brief, that's what I can say.
And finally?
Yeah, I'll skip the moderator's question for lunch. I'll just answer those for the audience. So to amplify community voices to get more support for community prioritization, I think the first thing is conferences like this that allows people to express themselves and say exactly what they experience in the field. That's the first thing. Secondly, there is need for donors to have community advisory groups or board, right, that are representatives from communities to tell them these stories the way they are. And then also it is important, even at national levels, to have consortiums, whether zero dose consortium or whatever that pushes some of these agendas. Lastly, capacity building, because to actually convince stakeholders on this requires a lot of skills. And then for the other question, level of government support in Cameroon to improve access to vaccination in communities such as the one I presented. Happy to share an experience where Clinton Health Access Initiative leveraged this kind of approach, but the difference is what we did is we instead set up a micro facility, right? And that micro facility was offering basic primary healthcare packages and vaccination. So just sufficiently to meet the need of 50% of this population, and then providing vaccination coverages. And as government's response to this, they adopted it as a state-owned micro facility and also sent health workers there. So there are ongoing efforts like that. Also, there is an ongoing project to test the use of mobile vans, you know, to see how mobile vans offering integrated health services, including COVID-19 vaccination, can work. So actually the government of Cameroon is quite open to innovations and is making real efforts, especially when we present them with the evidence. So thank you.
Thank you. Now, I don't know whether you're clapping for yourselves. Allow me, let us join hands to appreciate the panelists and to appreciate ourselves for joining this session. There is another session that will start at 2 p.m. on maximizing the benefits of all. I encourage you to go for lunch and then quickly prepare for the 2 p.m. session. Lastly is for the panelists, I think it's proper for us to have a group photo. To have a group photo here. It's just proper for memories of Bangkok. Thank you everyone for joining in, and I wish you a good lunch.